Park. My mom and dad are residents at Edmonton General Continuing Care Centre. My question is about basic healthcare services and enhanced healthcare services. The Alberta Hospitals Act establishes entitlement for all residents of Alberta to basic healthcare services and prohibits the charging of user fees and extra billing for these basic services. The Healthcare Protection Act differentiates between insured services and enhanced services which can be purchased. The enhanced services are defined as medical services that exceed what would normally be used in a particular case in accordance with generally accepted medical practices. My mom has advanced Alzheimer's. She requires more than 1 hour to eat her meals. Because she requires more care than Covenant Health can provide, her estate purchases companion services. Covenant Health keeps 40% and pays the companion 60% of the money charged to mom's estate. As well, her meals are now pureed so that she can more quickly be fed, but she is still provided meals that she can chew when her feeder has enough time. There have been instances when she's been given crisis because she's become dehydrated when staff don't have time to give her enough to drink throughout the day. So Covenant Health says that providing mom with these meals is enhanced care, and that's why the companions can be hired to do it. But it seems to me that given she has advanced Alzheimer's and she cannot provide food to herself, it would be a basic healthcare service. That's Covenant Health. Thank you.
Yes.
Thank you. My name is Jerry Shaw. My wife is currently in long-term care. We have been through the assisted living and the intermediary step of supported living and private locations. And I'd like to share with you just a few of my experiences. Incidentally, most of what you guys said up there confirmed my suspicions. Really. I made a number of recommendations for Alberta Health Services, which, well, we'll see what happens. Both my wife and my wife was a physiologist and a teacher of nutrition to nurses here in the Edmonton area. I did nutrition, non-human nutrition, in the early days of my career. It's a little similar. Both of us have advanced degrees from Cornell University. So here's what I observed during 24/7 caregiver time for me, particularly in long-term care. Case managers in home care, particularly in rural situations, cannot satisfactorily inform patients and their caregivers of how the system works. Many seniors do not use computers where much of Alberta Health Services information may be available. They use landline telephones, not cell phones. A few city caseworkers and social workers may understand most of how Alberta Health Service works. But when Alberta Health Service is constantly changing, these staff may be passing out-of-date information, which I suspect. In times of great change, the business-oriented mantra of doing more with less just causes more problems. And I really am starting to think there must be a subliminal virus in that mantra. It's affecting the politicians and the economists involved in determining what's going on in our healthcare system. You actually need more people entirely devoted to explaining how to work through the Alberta Healthcare Services as a patient or a caregiver. Number 3, healthcares need to be trained better, healthcare assistants rather, trained better to the operational level so that they understand completely why pills must be given on time for PD patients. And my experience lately, even though I gave them the National Parkinson's Foundation package from the States, which was made up for hospitals as to why PD patients need their pills on time, they lost it. And I also found 3 different people in that place who weren't giving my wife her pills on time because I go to see my wife every day. For instance, another thing, the healthcare assistants are subbing as food servers as well as taking care of them. And I think they need a lot more training in the area of cross-contamination of pathogens. My specific training, most lately in my career, was in the HACCP, Hazard Analysis of Critical Point Processes for food safety. So I know about all these things. So when I see a healthcare aide picking up a milk carton and putting their finger inside and pulling it open, I know they're not even thinking about cross-contamination. Now, I think they need more signage to show best practices to prevent cross-contamination, like what I just mentioned. They need to see blacklight demos of contaminated surfaces before and after cleaning. These can be posted where they won't be seen by the patients, because a lot of patients, particularly ones with dementia, will get scared out of their gourd by stuff like that. We don't need to do that. Healthcare schedules and cardiac recovery or rehab units schedules need to be coordinated better during the month with no driving permitted after leaving the CCU. A specific example of no communication between stovepipes in Alberta Health Services. Record keeping in private in Alberta healthcare residences needs to come into the digital age now. If you want more suggestions on this, you guys have it.
Thanks, George.
Stop.
No, that's good. Thank you so much.
My name is Patty Hartnagel, and my experience is from a slightly different angle, not from a long-term care facility angle per se, but from the orthopedic ward at the University of Alberta Hospital, which has essentially been turned into a long-term care facility, as I found out. I just had my second hip replacement in September, and within 3 weeks, the incision was infected, and so I had to be admitted through the emergency room to the University Hospital orthopedic ward for emergency surgery on an on-call basis. So the first day I was in a private room. It appeared to be, and this is all anecdotal because I wasn't in any condition to go around and really check things out very thoroughly, but it appeared to be the only single room, and I assume I was put in there because of the infection. So I stayed in there, had the surgery the next morning, and that same day of the surgery at 11 o'clock at night, the door flew open, the lights went on, staff came flying in, hauled me out in my bed, wheeling the bed out in the hall, all of my stuff, and they said, "We're sorry, we have a crisis on the ward, and we have to have your room." So they wheeled me into a 2-bedded room, and I became the second bed, so it wasn't overcrowded or anything, and I thought, well, time to try and go back to sleep after all of this. But unfortunately, and sadly, the woman that I shared the room with, who was quite elderly, suffered from dementia. And so she spent the entire night sobbing, calling out for her mother, arguing with her stuffed animals. It was absolutely appalling. The next morning, the nurse came in to explain what the crisis was that caused me to be moved. And it was an 83-year-old man, also with dementia, on the ward, who was threatening his roommate and threatening the staff. And even though they had gotten him moved out, they did not put me back in the single room again. So I spent more nights with this woman. And what was obvious was that this was a holding facility, really, for frail elderly who had fallen, broken hips in their home. Most of them appeared to have dementia. There was an incredible amount of yelling and screaming and noise going on in that ward. And none of these people could return home. Now, every room has a whiteboard for every patient, and the whiteboard for the woman in the room with me said that she had had her hip replacement surgery in July 23rd. She was well enough to be placed in a long-term care facility for dementia patients August 16th. It was now October 4th, 5th, 6th, 7th, 8th, 9th, and she was still languishing in this bed. And from what I could gather, it looked like there were about 4 of us who were not frail elderly being warehoused on this ward. So it's an extraordinary situation when you have the so-called bed blockers tying up the vast majority of beds in a ward like this. And this was before the snow fell. One of the nurses said, oh, things were easy right now because the ward was only full. Once the snow and ice hits, they have to have 3 people to a room and people in the hallways. And so it's an absolutely inhumane situation. It's a total disservice to the elderly people that are being warehoused there and not in a calm, predictable environment. Total chaos in that ward as it is. And it's a disservice to the nursing staff who has to spend a good chunk of their time managing behaviors and crisis management all of the time because of the condition of these people. And for patients like me to be very selfish, it doesn't help to have undergone 3 surgeries in 3.5 months and be placed in a room where even with earplugs and noise-canceling headphones, I can't get any sleep. I was told to either take a nap all morning while they moved her out in the hall, or they would give me sleeping pills, which is not quite what I had in mind when I went to the hospital to develop a dependence on sleeping pills. So, this is an untenable situation for everyone who's involved, and on top of that, it is hardly economically viable. I have heard, and I'm not sure this is accurate, but that active treatment beds cost something like $3,000 a day to maintain. So this is obviously a failed economic policy, a failed policy for the seniors, for the healthcare professionals. It's just a disaster, and that was 1 ward in 1 hospital in 1 city.
This gentleman right here, Joel. So we'll take a few more, and then we're going to give the panel an opportunity to comment. So people want to just signal to me. I'll try and keep a bit of a secret list there. So Dr. Sherman at the back. So, sir.
Me and my cousin went on trips numerous times. One time she got sick.
Can you take the microphone towards you so that you're speaking straight into it? That way we'll hear you.
One time we went to Hawaii and she got sick. We had to stay there extra 3 months because her heart needed a valve. Anyway, they come back 3 weeks and the valve was supposed to last 12 years. It lasted 18. So she needed one 3 years ago. She survived the operation, and my cousin says to me, he says, you know what? He says, you have a van, and I've got a truck. Would you kindly come with your van? Because my wife is ready to come home tomorrow morning. He phoned me at 1 o'clock in the morning. He says, Harry, don't come, because my wife died from staph infection, and that was at the University Hospital.
Bill, thank you so much for the presentation. To everybody, you're absolutely correct. I authored the overcapacity protocol in 2006 worked with UNA and the AMA and the government in response to miscarriages and deaths that happened in Calgary emergency departments. Overcapacity protocols are where we put sick patients, some of them infected, 3rd patient into a room for 2 or a 5th patient in a room for 4. They were in response to a crisis. It's a short-term solution. 6 years ago, every hospital has been using them throughout the year. So essentially the system has been in crisis. We have spread sick infected patients throughout the hospital on the wrong wards, the wrong hallways. We're not supposed to have these circumstances. Certain facts: Alberta is spending 43% more in healthcare compared to 5 years ago. $17 billion in healthcare spending. It used to be $11.9 billion in 2008. And the population is only gone up 11.1%. The whole emergency issue is a system problem. It's not an ER problem. Despite that money being spent, this week, admitted patients are only going up upstairs, not even to the most appropriate ward, in Edmonton 28, 45% of the time. So the question we have as a society have to ask is, where's all of our money going? When that much extra money is being spent in healthcare, I'll tell you, the staff have not gotten pay raises. We haven't paid new staff. What the government is doing right now on the acute care wards, with an ever-increasing complexity of the patient on a medical ward, and wards that have overcapacity patients, they're actually decreasing the number of RNs as we speak today. In fact, they're probably going to compliment the staff that we should actually have a long-term care facility on acute care wards. Now, what we find as frontline health providers is that the acute care system has become the de facto fallback for the for-profit private home care, long-term care providers who can't make money with patients that have such high needs, so they're essentially just bringing them back into acute care. What we also find is because of such inadequate home care, because of the profit that has to be made, many people, it is my sincere belief, are being placed that don't need to be placed. If we just, 80% of people going into long-term care come straight from home, because there's such inadequate home care. If we did what the Danish do, there's such world-class home care, subacute care, rehab care, community-based hospice care, people can age and live in their own homes and their own communities with dignity and respect. If we just got all of our seniors all the support that they need, the acute care system could today function at 85% capacity, and it would actually save us money. It would save us money. So I just thought I'd give you certain facts and certain information, and the Parkland report is absolutely correct on the long-term care. Dr. John Cowell wrote a report in 2012 saying for-profit care is far inferior to non-for-profit, community-based public care. And exactly the same thing as the Parkland report. So the question has to be asked Dr. Cowell, why is he condoning this kind of care now that he's in charge of the system? Thank you, and keep up the good fight, everyone.
Kevin? We got Kevin over here. Eddie, and then we'll do a quick wrap up at the end. This is
my mom was in the system for 3 years. If I started on her story, it would shock you just as much as any we have heard. My reason for standing is something else. A few years ago, when I was working with a political party, I happened to be seniors president for the federal party, Liberal Party in Alberta. And we were told that research exists that says seniors, when they are proselytizing, trying to get support for a certain idea or pointing out facts to their members of their communities, have far more sway in bringing people on board to understand the facts than any other age group. So here we are, it's kind of an irony. We are the seniors getting a raw deal, but we're not the only ones in the province getting a raw deal, but seniors are placed in the best position to do something about it by telling their neighbors.
Thanks. A friend of mine gets home care, and I spoke to Steve Young, and I'm not very good at talking to him. I guess he sent a letter to, what's his name, Fred Moore. Yeah, and she no longer gets service from Rivera. She gets service from some other outfit, but that doesn't seem to be working much better either. Sometimes nobody shows up, and she phones and says nobody's coming, and she doesn't connect. She speaks to an answering machine, and sometimes people come at the same time, 2 people come at the same time, and she can't really organize her day. But this is not really seniors, this is home care. And another thing, I heard on the news today about this fantastic lab they're putting up, which is supposed to be private, I guess, and it's going to speed everything up. So we have to fight. We have to fight.
Thank you so much.
I just stayed this long because I want to know what we are going to do.
Yes.
Because my mother-in-law had Alzheimer's a number of years ago and died, and during the time she was hospitalized, she did have a number of the same kinds of experiences that have been described here tonight. And nothing has changed, in fact, it has gotten much worse. And I just don't know what we can do, and I somehow think that as people, we have to be able to be much more proactive as a group, and I would just like us to do something.
Yes.